Hello, and welcome to this edition of Simon Says, our expert series. My name is Dr. Shelley Johns, and I am an associate professor of medicine at the Indiana University School of Medicine. I'm also the Walther Scholar in Psycho-Oncology at the IUPUI Comprehensive Cancer Center. I'm also a researcher at the Simon Comprehensive Cancer Center and a research scientist at Regan Street Institute. I am delighted that you have decided to join us today for this really important topic in support of cancer caregivers. So during today's session, the Simon Says session, our experts are Dr. Kristin Levoy and Dr. Catherine Mosher, and I will introduce you to both of them momentarily. Both of them focus on caring for the family caregiver, and they discuss ongoing research efforts that are geared toward enhancing support for these family caregivers. So from Dr. Levoy, we will learn about her research efforts to enhance communication among patients, caregivers, and healthcare providers in the outpatient oncology setting. And then Dr. Levoy will also share with us some of her prior research that underscores the value of caregivers in healthcare delivery. And then we will also hear from Dr. Catherine Mosher, who will discuss her exciting research on telephone counseling approaches to improving the well-being of family caregivers of adults with cancer. So I am thrilled that you are here with us today, and we'll be sharing expertise on this important topic. I wanted to just start by sharing just a quick fact with you. And that is that there are an estimated 1 in 5 Americans are providing care to a person dealing with a serious medical condition. And 20% of those caregivers are cancer caregivers. So about 3 million cancer caregivers right now in the United States. And while caregiving can be rewarding, it can also affect a caregiver's physical and emotional health. And so this multifaceted approach, multifaceted approaches are needed to provide the care that's needed for these caregivers. So I am so excited to pitch to Dr. Kristin Levoy right now, who will get us started today. Thanks, Kristin.
Thanks so much, Dr. Johns. Is everybody good for the slideshow here? Great. So I'm absolutely delighted to be talking to everyone today. It's one of my favorite topics, caring for the family caregiver in the Simon Says Expert series. Just to ground us a little bit in the caregiving context, I thought I'd start with some introductory comments about the state of caregiving in the United States to ground us in really what are the care needs of cancer caregivers. So if we look at just general definitions, when we look at American Cancer Society's definition of a cancer caregiver, it is the person who most often helps the person with cancer and is not paid to do so. And the relationships of cancer caregivers can vary quite dramatically. It may be a spouse, a partner, a parent, adult child, sibling, a close friend, or even neighbors. And if we look at a recent report, and Dr. Johns alluded to some of these statistics just a few moments ago, the National Alliance of Caregiving has recently updated their report on caregiving in the US in 2020. And that was an update from statistics in 2015, where there was an increase from 43.5 million Americans providing caregiving in the United States in 2015, and it increased to 53 million in 2020. This represents 1 in 5 Americans providing some sort of caregiving services, and really underscores how much caregivers do actually support our economy, and that they are providing, this is based on an older estimate of $522 billion of unpaid healthcare delivery a year. And again, this estimate is probably much higher in today's standards. And 6% of these 53 million caregivers do report that they are caring for a person where their primary care needs are rooted in cancer. So this represents right now a little over 3.2 million cancer caregivers in the United States, an increase from 2.8 million in 2015. They did a little bit of a deeper dive on what cancer caregiving looked like in this report, in this picture. And what they were trying to do is try to understand the differences of the cancer caregiving context compared to caregiving for other serious and chronic conditions. And what they found was that while the duration of time that caregivers are providing care is a little bit shorter than other illness states, an average of 1.9 years of caregiving services provided, in other illness states, it can extend to upwards of 4 years. The amount of care, while is shorter in duration, is much higher in intensity with respect to the complexity of the services that are being provided, as well as the number of hours on average a week, which were 33 hours a week in 2016, which equates nearly to a full-time job, which is really just shocking. And in other illness states, the average was around 24 hours a week. And to any of the caregivers that are on the call today, these types of describing what a cancer caregiver does should sort of resonate and hit home with you. They, in this report, really quantified the extent of services that caregivers were supporting, one of them being activities of daily living, where we define 6 common activities of daily living, ranging from transferring, toileting, dressing, feeding, bathing, and incontinence management. Cancer caregivers on average are providing 2.4 of these 6 services, compared to non-cancer caregivers are providing 1.6. The starred ones here in transferring and toileting represent 50% or more of patients, caregivers are supporting transferring needs as well as toileting needs of their patients with cancer. In addition, caregivers also support other instrumental activities of daily living, and these things include transportation, housework, grocery and other shopping, meal preparation, giving medicines, managing finances, and arranging outside services. Again, cancer caregivers topped other caregivers in the amount of these services that they're supporting. And these stars in this list represent 60% or more of cancer caregivers reporting providing these services to patients with cancer. But beyond these sort of day-to-day duties, cancer caregivers are really involved in complex care management and helping patients with cancer navigate their treatment. And this could include providing complex medical or nursing tasks, such as facilitating tube feedings or managing a colostomy bag. It also includes monitoring symptoms and reporting any problems with the medical team, and coordinating care across transitions, like a transition from the hospital to the home. So this is a lot of services clearly that caregivers are supporting. And like we said, if we quantify that, it really amounts to a full-time job. And despite some of these burdens that caregivers, or the services that caregivers are providing, they do report a significant benefit of cancer caregiving and just the satisfaction in being able to provide those services for patients, the personal growth achieved. It allows them the opportunity to reevaluate life priorities and potentially get closer family bonds or spiritual or religious bonds. But as you can imagine, with the breadth of services they are supporting, it does take a toll from a physical and a psychosocial perspective. There's a high emotional stress reported by cancer caregivers, or high levels of distress, anxiety, depression, or even post-traumatic stress disorder, as well as deterioration of their own physical health, inability for them to meet their own healthcare needs, increased fatigue and insomnia, and financial strain, particularly among those caregivers that are still actively working, and the strain that the weight of caregiving can cause on their inability to work. So if we look at the range of needs that caregivers really report, they range across 5 domains: spiritual needs, informational needs, physical needs, social and emotional needs. And if you look at the examples in this table provided under each of these needs, these represent not only needs with respect to their caregiving role, but also personal needs with respect to their own health. So really the way in which we sort of need to conceptualize supporting caregivers is not only what they need to serve as a caregiver role, but what they need to support them as a person. And these range of supportive care needs does fluctuate across a cancer illness trajectory, and in that some of these supportive care needs will increase as a patient's prognosis worsens. They also can look a little different depending on whether or not the caregiver lives with the patient or is a long distance caregiver. The level of complexity of the services that they are supporting in the home, the presence of others. Often caregiving is a team sport, and there's not just one primary caregiver, but multiple caregivers that may be involved in supporting the care of that patient. Whether or not this person is serving multiple caregiver roles, there's something called the sandwich generation, where adult caregivers are providing care not only for their parents, but also at the same time being parents themselves. And you can imagine that makes the complexity of serving in the caregiver role that much harder. Also considering the health state and well-being of the caregivers themselves and their capacity to support this care, given their own mental and physical needs, and any sort of financial situation or lack thereof, and lack of access to support can all make this caregiving context much more complex. So when we think about supporting caregivers, as I've mentioned, we really need to think about what they need to serve in their role as a caregiver, but what they need as a person. And despite this recognition, if we look at some of the statistics, nearly half of caregivers have not been asked by a healthcare team what they need to help care for the patient. And more than 2/3 of caregivers have not been asked by the healthcare team what they need for their own self-care. And those are pretty astonishing statistics. And some of my own sort of research interests really sort of arise out of some of these astonishing statistics. If we look at sort of a common scene at the bedside in the inpatient setting, we can think about the types of supportive care that a caregiver may need in this setting, where some of my concerns are, just how engaged are caregivers in these interactions? Are they really treated as an integral part of the team in planning the patient's care, such as maybe when they're being discharged home? How actively is the healthcare team partnering with that caregiver to support their needs in supporting the patient's care? And again, when we transition to the outpatient setting, we recognize in cancer care is increasingly moving into the outpatient setting. So what happens to the caregiver in that context? Is the healthcare team really optimizing the time that patients and caregivers that they do actually interface with the healthcare system to provide the right supportive care at the right time? And it's some of these questions that really sort of have taken me along my research path and my research journey. And I'm going to highlight 2 specific studies related to these 2 questions. Related to the picture with the patient or the caregiver in the inpatient hospital setting, I conducted a research study. It was a meta-analysis which looks at caregiver engagement in interventions that we do to help them. And what this type of study does is it involves an extensive literature review of the existing interventions that are out there to support caregivers across transitions in health. And when we think about transitions in health, the transitions refer to transitions across healthcare settings, like a discharge from hospital to home. And these blue boxes really represent a range of services that caregivers may be involved in helping transition that patient back to the home setting, where engaging caregivers is a critical aspect of these interventions. So we did a literature review and we were able to identify a total of 54 interventions or studies that did transitional care. And these studies encompassed over 31,000 participants. We were trying to understand, and this is sort of a busy table, but the intention is to show you here in this right-hand column, you can see that there are little statistical findings that come out of each study, and we recalculate these as a statistical whole. And it gives us an idea of how impactful these interventions are when we consider them in a collective fashion. And here we looked at studies that had caregivers that were engaged in those intervention components and studies that did not have that engagement. And we found that studies that did engage caregivers in that those transition intervention components had superior outcomes. Interventions with caregiver engagement resulted in an 18% reduction in the risk of patients being rehospitalized at 2 or more months. If patients are being successfully set up after discharge, we shouldn't see them coming back to the hospital. So this caregiver engagement was a crucial aspect in helping patients successfully transition home. And interventions without that caregiver engagement had no significant influence on these patients' rehospitalization. So these findings, and we really sort of understood the value that caregivers bring to the table, but this provides a little bit of mathematical power behind that statement and saying that caregiver engagement is really a critical feature of transition care interventions that really help improve patient outcomes. We also looked at those interventions, and caregivers were typically involved in things like a baseline needs assessment. They were involved in the discharge planning process as well as in service coordination. And so we made the conclusion that it's really a caregiver engagement in these interventions. It's critical to helping improve patient outcomes when they're bundled with these broader sets of services like the ones listed above. Referencing that second picture of the young couple in the outpatient setting, my most recent research is really looking at a rapid communication intervention in the outpatient setting, where I'm hopeful to enhance the communication that's happening between the patient, caregiver, and provider in that outpatient oncology setting. And this study is just getting started up, but it really got started in sort of recognizing the fact that patients with cancer are living longer with their illness, and that's owing to advances in treatment. But that means that they're facing the illness for a longer duration. And as the illness progresses across the illness trajectory, so does the complexity of the care they receive. This combined with the fact that outpatient oncology care is increasing and care is moving out of the hospital setting, this really collectively means that patients and caregivers are increasingly navigating complex supportive oncology needs increasingly at the home, and really needing us to think about how we can better support patients and caregivers when they do interface with us in the outpatient oncology setting. If we look at existing sort of studies of communication in the outpatient oncology setting, we see a lot of this communication really is provider focused, where the providers are really talking to patients and caregivers directly, and their conversation content takes up over 70% of those encounters, where they're really focused on making sure the patient's labs are okay, addressing side effects from treatment in order to get them to their next treatment appointment. But this leaves really little time for the patients and caregivers to express their concerns. And so the intention of our intervention is really to sort of flip the conversation around so that patients and caregivers are able to bring up their needs and facilitate communication that's more balanced across the three participants. And in an effort to sort of move the conversation away from the sort of more clinical and diagnostic aspects of care to these broader range of supportive care services that patients and caregivers need, and these sort of wraparound supportive services that are really critical to the patient and caregiver's cancer experience. The intention behind this is that hopefully with these types of interventions in the outpatient setting, we're not only improving the patients and caregivers' experience of care, but also enhancing their ability to make decisions and also enhancing their psychosocial well-being. With that, I'll stop my sharing and flip the slides or skip to Dr. Mosher for her presentation.
Well, thank you, Dr. Levoy, for an excellent presentation. Sorry, I need to get to my first slide there. Okay, so today I'm going to present a pilot trial that my team conducted at the IU Simon Cancer Center and Eskenazi Health, where we tested a form of counseling called acceptance and commitment therapy. And the target outcomes of this trial were the degree to which fatigue interferes with functioning for patients, as well as family caregiver burden. And the focus of this trial was advanced gastrointestinal cancer. So first, a bit of background. We know that fatigue is a very common symptom in cancer in general, and also in GI cancer, and it often interferes with important activities. And the word caregiving burden means that the impact of caregiving on various aspects of a family caregiver's life. And this burden has been associated with impaired quality of life, which we often define as mental, physical, and social well-being. And what we see clinically is that caregivers with a higher degree of burden often care for the patient to the detriment of their own self-care, which has health consequences. And so far, effective interventions are lacking. We have not found effective interventions for fatigue in advanced cancer. And in terms of the cancer caregiving literature, most of the focus is on early stage cancer, and often there's no distress or symptom criterion for caregivers' eligibility. So in other words, the trials are not focusing on family caregivers with the greatest need for intervention. So to begin to address these limitations in the literature, we aim to evaluate both the feasibility and acceptability of delivering telephone-based acceptance and commitment therapy, or ACT, to patients with advanced GI cancer and their family caregivers. And I already mentioned the target outcomes, and this intervention was compared to an education support control condition that I will describe in a minute. So in terms of the patient eligibility criteria, the patient had to be diagnosed with unresectable stage 3 or 4 GI cancer and report moderate to severe interference of fatigue with their ability to function. They also had to have a consenting family caregiver in order to participate. We defined family caregiver very broadly. It could be a family member or a friend who was living with the patient or had visited the patient in person at least twice a week for the past month. So we wanted somebody actively involved in the patient's care. And they also had to report moderate to severe caregiving burden or distress. So here's an overview of the study design. This study took place during the pandemic, and everything was done over the phone. So there was a baseline phone assessment with patients and caregivers, and then the dyads, the patient caregiver dyads, were randomized to either 6 phone sessions of ACT over about 6 weeks, or 6 time equivalent sessions of education support over 6 weeks. 4 of the 6 sessions were delivered dyadically. In other words, the patient and family caregiver participated together on speakerphone, whereas the 2 remaining sessions were delivered individually. So we were trying to meet both the shared and unique needs of patients and caregivers. And then there were follow-ups conducted at 2 weeks and 3 months post-intervention. So I'll describe this intervention, although it focused on both patients and caregivers. Because this is a webinar on family caregiving, I'll describe the intervention with reference to family caregivers. So mindfulness exercises promoted compassion awareness of their thoughts and feelings about caregiving. Caregivers also learned adaptive coping skills such as acceptance of their uncontrollable circumstance and perspective taking. And what we noticed is that many caregivers did have identified that their personal health and well-being was an important value to them, and they took action steps consistent with this personal value. For example, caregivers set goals to re-engage in a regular walking practice, or even drink more water, but little small but feasible changes that could help enhance their health and well-being. And the education support control condition was similar to interventions that social workers deliver every day at cancer centers. So patients and caregivers were oriented to their medical center. A variety of quality of life concerns of both the patient and caregiver were discussed. And the dyads received contact information for both medical center and community resources to address these concerns. Tips for evaluating health information available on the internet and in other formats were reviewed. So here are our outcome measures. We defined feasibility as enrollment and retention rates. Acceptability of the intervention was defined as helpfulness ratings, and outcomes were assessed via standardized measures. So here are the results. It was during the pandemic. I had no idea what to expect in terms of enrollment, but we had a solid 54% agreement for eligibility screening among patients, and almost all caregivers agreed to the eligibility screening. 100% of eligible patients and caregivers consented. And I would like to note that most of the withdrawal or attrition, almost all, was due to severe patient medical issues or death. In terms of acceptability, the intervention received high helpfulness ratings from both patients and caregivers, and even slightly higher among caregivers, as you can see. So to orient you to this table, so you're examining within group change in the primary outcome variables for the ACT and education support conditions. And what we see here is moderate change over time, moderate reduction in patient fatigue interference for the ACT group, where we don't see this change. We don't see any decline in the education support control condition. We also saw a medium reduction in caregiver burden at the first follow-up in the ACT condition that was not sustained over time at 3 months. And we see very little change in caregiver burden in the education support control condition. So to summarize, results suggest that our intervention is feasible and acceptable to patients and caregivers. If you look at the dyadic psychosocial literature in cancer, our enrollment and retention rates were above average despite the pandemic, and the average helpfulness ratings for ACT were high. So we speculate that for patients, mindfulness might have led to reduced perceptions of fatigue interference. And one way it could do this is by interrupting more maladaptive reactions to fatigue, such as ruminating on the fatigue or catastrophizing, like assuming the worst possible outcome, like, I will not be able to function at all because of this fatigue. And ACT also emphasizes living consistently with values, even when fatigued, rather than symptom reduction or attempting to control the fatigue. This might seem like a subtle distinction, but it affects what we look at as our primary outcome variable. And we hypothesize that for caregivers, mindfulness might have promoted compassion and acceptance of thoughts and feelings about caregiving. And indeed, this was supported by our qualitative data with interviews with caregivers in this study. And we also hypothesize that ACT's focus on life values, again, could lead to feasible re-engagement in these self-care and other activities neglected due to caregiving. I would like to note that this is one of the first studies of ACT with caregivers of adults. Almost all ACT studies with caregivers to date have examined caregivers of children with chronic conditions. Limitations to the study include the small sample size and the primarily non-Hispanic white sample recruited from only 2 medical centers in Indiana. So to address these limitations, I have a proposal under review, should be reviewed this week, to examine this intervention in advanced GI cancer. So this is a large-scale trial in several cities. I also propose a booster session to hopefully sustain that effect on caregiver burden over time. And training in ACT is widely available online and in person. So my hope is that if we find this intervention to be effective, we could readily disseminate it. I'd like to acknowledge the National Cancer Institute for supporting this study, as well as Dr. Johns, who's in this meeting, and many other people who played a vital role in this research. So with that, I will turn it over to Dr. Johns for the Q&A.
Okay, well, thank you both so much. I have learned a lot from both of you, as I always do, and hopefully our audience would agree with that. We have, I think, 5 questions that have been written in so far today. So I wanted to start with the first question, and then I'm not sure if Dr. Levoy or Dr. Mosher will be answering this one, but I'll put it out. So the person writes in, if you don't live in the same town as the caregiver, if the patient doesn't live in the same town as the caregiver, how can the caregiver best support the patient from hundreds of miles away? Just listen? That was the question.
Great. I was so happy to see this question come in. I actually prepared a few slides. I think there's a lot of really great online resources for distance caregivers. This is really an emerging phenomenon. Over 6 million caregivers in the United States are providing long distance care, and that's an increasing reality among the caregiver experience. We do define distance caregivers as those that live just as little as 1 hour away from the person they're supporting care, but oftentimes that distance is much greater. I did pull some supportive suggestions of how distance caregivers can support their care recipients from a long distance away. And to your point, this just listen sort of part of your question was well supported. I looked at the cancercare.org, cancersupportcommunity.org, cancer.gov, and also cancer.net. All really nice resources that have some really great caregiver-facing tools to help you think about sort of more broadly how you can help patients. And certainly just listening is an amazing resource to patients. Regular communication is really a powerful way to offer emotional support. And these resources really emphasize the regularity and that planned commitment to that communication, particularly as there's usually an outpouring of support at the time of a patient's diagnosis, but sometimes that support can trickle away with time. And so that sort of regular commitment to talking and providing that emotional support is really seen as valuable. But some other more tangible recommendations were things like becoming a point person to help coordinate medical appointments. We know that managing the variety of appointments that a cancer patient might have with their oncologist, with other radiation oncologists, other integrative medicine doctors, as well as their primary care, can get mind-boggling. So having someone sort of take the reins on managing those records and those appointments. Again, looking at some local sort of a social network to coordinate support for that patients, particularly maybe around high symptom times, like times of treatment, looking at arranging meal support, having a calling tree that the patient maybe identifies those folks that are around them that may be of assistance, and maybe there's some sort of hierarchy that's established, and there's a commitment from parties on that calling tree to follow through on that support. But that is, the idea is that it's patient derived, but then it's communicated amongst all the parties so everyone has it when issues do arise. research into long-term or temporary in-home community-based support services beyond meal preparation and maybe having someone's groceries delivered. There's some sort of in-home things like, basic maybe issues with fixing things that come up, or house cleaning, and doing that support for them and arranging those services. Maybe being the point person of sharing updates. Clearly, a lot of our loved ones, when we're going through a cancer experience like cancer, everyone wants to check in and see how it's doing, but managing all those calls and group texts that are coming in can be quite exhausting. So, taking the reins of the group text and providing those updates on the patient's behalf, or managing the website. Cancer a support community uses My Lifeline as a way to for people to communicate. There's also Caregiving Bridge and some other online websites that caregivers can use to post regular updates about the patient's illness experience. And then help them to get organized. Again, there's sort of a broad range of sort of more practical needs around household finances, paperwork that needs to be arranged, maybe talking about advanced care planning. So these are some really nice, I think, tangible ways that distance caregivers can meaningfully support patients in their cancer journey.
Well, thank you, Dr. Levoy, for those actionable steps. I think we really appreciate that. The second question is this one. I am a caregiver to my spouse, and she has a mental health condition and is also being affected physically. So I am having a hard time in getting her to eat and drink. How do I get her to eat and drink more?
Yeah, I'll take this one, I guess. If you want to chime in at any point, Dr. Levoy, feel free to do so. First of all, I'm really sorry you're dealing with that. It sounds like a frightening situation. It was one of those questions where I'd like to ask 10 follow-up questions to fully understand what you're dealing with. And my answer, for example, would differ if this is a severe mental health condition. Perhaps, they're out of touch with reality versus, more mild to moderate problem. But in any case, I still think there's a few pointers that I can offer. One is certainly, I would wonder, is your spouse connected to the mental health system, and how can you encourage and support them to be connected? So that's one question I have. And even if your spouse refuses mental health care, you yourself can see a professional and talk in much greater detail about the situation that you're facing, and get advice on how best to support your spouse. And then the last thought I have is, also your spouse could be evaluated for any medical condition that could be contributing to the problem, such as GI issues. I'd also want to know if there's any medical factors involved there. And my last thought is, in general, to say the obvious, we can't change our spouses. So rather than telling her what to do, is there a way that you can be honest and vulnerable with her? Say, I'm really concerned about, fill in the blank, these behaviors, and any fears that you have moving forward. And usually that opens up a dialogue with your spouse to understand, her perspective. Is she trying to lose weight? Is she depressed? Is she, what is she going through? But being honest and vulnerable, I would say, is step one.
Okay. All right. So thank you, Dr. Mosher, for that. We have a third question that might actually be a little related to the question that we just heard. And that one is, what resources are available to help families decide when hospice, may be the appropriate?
Do you want to take that one, Dr. Levoy, or do you want?
And I'm always happy to chime in as well if that's desired.
Yeah, I mean, I think that that some of those initial conversations typically happen with the oncology provider. And that's a great sort of starting point for having an honest conversation. I think there are sort of milestones in a cancer illness trajectory where it's important to sort of revisit those conversations, maybe when a patient has had a recent progression on a CT scan, or their tumor markers are increasing, or they're not responding to treatment. Those time points in a cancer patient's illness trajectory are really meaningful times to connect with the oncology provider about what prognosis is looking like and sort of planning for the future.
Yeah, I agree. And, one of the other options at many cancer centers these days is to ask the oncologist if a referral to perhaps a palliative medicine or a supportive oncology professional would be in order. I know most IU Health cancer centers currently have palliative medicine or supportive oncology professionals who can also help weigh in and offer some guidance on when that step may be needed as well. So. Okay, we have a couple more questions here, and I'm mindful of our time as well. So our next question is a really specific question, and this comes from somebody who is an adult nurse practitioner. And this person says that they're going back for their certification as a psychiatric mental health nurse practitioner. And this person is interested in the population of people to treat when they finish their education in May. Then they say that their daughter was at Riley for a while when she was treated twice for leukemia, received a stem cell transplant, and then the person says that she and her husband had really understandably high anxiety that she describes as terrible, and said that they had a hard time finding anyone who really knew about the cancer world and PTSD and anxiety treatment. So this person just wonders, is there a role for a psychiatric mental health nurse practitioner especially in kids who are going through critical illnesses and supporting their family caregivers?
Yeah, I'll put on my nursing hat and advocate for nurses right now. I'll take the first pass at this. I did want to circle back just really quickly about the hospice question, just to be clear that a patient, just to be eligible for the hospice benefit, must have a physician determined 6 months or less to live. So there needs to be that terminal diagnosis. However, palliative care clinicians, as well as the oncology provider, can be brought in advance of this to sort of have these conversations earlier and plan for the future. So even if you're not, the person with cancer is not in that sort of time frame, it's still, there's opportunity to have those discussions in advance. Just in case that wasn't clear, I wanted to make that clarification. So this piece about the mental health nurse practitioners, I think the short answer to your question, and I did pull up a few slides because I think it is a really compelling question and really underscores some gaps in sort of our care delivery at this time. Is there a role for psychiatric mental health nurse practitioners out there, especially for kids going through critical illnesses and treating their families? Absolutely. I think that nurses and as well, especially nurse practitioners, are really trained in sort of recognizing these symptoms of distress earlier on and assessing those symptoms of distress and getting them to the appropriate resources and referrals. So I feel like nurses are really on the front lines of recognizing that this is an issue and partnering with parents as well as the children with cancer in order to get them the right supportive care resources. I started to look just in the research literature just to try to understand what was out there and sort of what interventions are on the horizon for mental health nurse practitioners to maybe fill this gap. And there's been a lot of tools developed by nurses and nurse practitioners in supporting parents, particularly at the time of diagnosis. And this is a particular primary topic, a checklist that was developed by Dr. Rogers and colleagues, where they were looking at the range of sort of things that need to be done at the time of a child's diagnosis to sort of support them and sort of prepare them for the illness trajectory. However, there seem to be less out there as far as when patients either progress across an illness trajectory, and for those parents that their children succumb to their illness, and or those that do survive. And there's clearly supportive care needs in both those capacities. I was just looking at some of the interventions that they suggest to assist family members more broadly with coping across the illness trajectory, particularly when the prognosis is worsening, is really having honest conversations around the prognosis, having the family sort of mobilize some of those more sort of their social network to support the care, encouraging family members to take time. There is some process of anticipatory grieving, and there's support services for that. So these are just a couple tools that were mentioned by the Oncology Nursing Society of typical interventions that may be helpful. And there is a telehealth delivered group-based therapy session that was developed by some researchers in Australia to support parents of children with critical life-limiting illnesses. The initial trial showed while parents were really satisfied with the service, it didn't seem to really move the needle on some of these psychosocial outcomes that you mentioned. So I think the jury is still out, and there's some sort of emerging work in this area, but sort of relevant to more immediate needs. I looked at the cancer support community of Central Indiana. There are individual counseling that's available, and usually 5 to 10 sessions are provided. There's in-person support groups for friends and family, and there's one specific to pediatric cancer moms, a virtual support group that's offered monthly, as well as that friends and family support group offered monthly online as well as in person. And I don't know if Dr. Mosher or Dr. Johns has anything to share with that.
Well, I'm getting ready to share, and I can't tell right now if my slides are shared. Can anybody let me know? Okay. All right. Well, we do need to wrap up because we are out of time. And but I wanted to just share a few resources, but for some reason, my screen is locked up here. Give me just a second, and then we will. I just wanted to put just a few options online here so everybody will have those. Give me 1 second, then I'll scoot back. There we go. So I just wanted to share, because one other person did ask some questions about financial and mental health resources, and Dr. Levoy has already started sharing there, but I did want to let you know that every IU Health Cancer Center has an oncology social worker or multiple social workers, and they are an absolute wealth of resources for both financial and mental health support. Emotional support. And the 5 different options that I have listed here go beyond, Dr. Levoy had already mentioned the cancer support community, but these are the 5 that you probably want to have on speed dial, on your internet browser. Because each of these can offer very specific steps that a caregiver and or the patient can take for financial support, as well as for emotional support. And the emotional support one is primarily through cancercare.org, because they offer individual as well as group support. There's also the option, if you are a caregiver, family caregiver of a person who is being treated for cancer in the IU health system. We do offer caregiver wellness coaching. It's very brief, usually 6 sessions or less. It's based on a model that's very similar to what Dr. Mosher spoke about in her session. If you're interested in this, regardless of which IU Health Cancer Center you're being treated at or your person with cancer is being treated at, you can give me a call, and you've got my personal number there. And then I'll just go ahead and leave this on the slide as I mentioned what is coming up next month, just in about 10 days, for the Simon Says series. The topic will be talking about what matters most, planning for a successful office visit. And that sounds very relevant to everything that Dr. Levoy talked about. So you can register for that session and find a recording of today's session if you'd like at cancer.iu.edu/Simon Says. Thank you so much for joining us, and we wish you all the best in your cancer journey. Thanks again.